Hey everyone, hope you're doing well. Nate Lighthizer here, faculty member at the Oklahoma College of Optometry, talking to you today on ERG, handheld ERG, the RETeval, and the photopic negative response protocol, the protocol we use in our glaucoma patients to help test what's ganglion cell function doing. And it gives us so much confidence. Should we monitor? Should we refer? In glaucoma, should we add treatment? Should we continue to monitor and hold where we're at? Are they progressing? Are they not? Do they have glaucoma? Do they not? They're giving us confidence. Knowledge is power. Looking at structure and function, and ERG, in this case, the photopic negative response, a protocol on the handheld RETeval gives us that objective functional data and how are the ganglion cells functioning there. So again, I'm a faculty member at the Oklahoma College of Optometry. Objective functional data gives you more confidence, structure, and function. Experience with an ERG flow is so easy now to be able to take this handheld ERG to the patients. They love that. I describe it as the EKG to patients. They all know what EKG are. To get a complete cardiac picture, you would want an EKG. To get a complete retinal picture, complete glaucoma picture, you want to get an ERG as well. Again, take it right to the patient. These can be dilated. Most of these protocols can be done undilated as well. Quick, simple, easy, patient-friendly, doctor-friendly, staff-friendly. Let's look at a case. 32-year-old female referred in for special testing to determine, is this glaucoma? Is it not glaucoma? She'd been diagnosed with glaucoma 5 years prior at a very young age. She's 32 now when I saw her, and she was 27 years old when she was diagnosed with glaucoma, put on a prostaglandin analog, has been on the drop for the past 5 years or so. But however, she was a realtor. She is a realtor. And she flat out told me on my visit, I stopped my drops 5 months ago because I got tired of my clients asking if I was smoking dope. I got tired of them saying, why are your eyes so red? She self-stopped her eye drops, her glaucoma drops, the prostaglandin 5 months prior. So she's been treated for glaucoma, but when I saw her, she was no longer on glaucoma therapy. So you take a look at her information here and visual acuities. You can see her prescription, IOP history, on the drops, off the drops, off the drop. She'd self-stopped her prostaglandin analog in between these two visits. So you can see, was the drop doing a whole lot? Not really. Pressure's 13 when I saw this particular patient. Central corneal thickness, again, slightly thinner than normal, but overall pretty darn close. Here's why she has been a glaucoma suspect or diagnosed as a glaucoma patient. You take a look at those optic nerves, and whew, that certainly catches your attention. The right eye and the left eye. And I will tell you, these photos make the cups appear smaller. Yes, I said smaller than they were in real life. Those are pretty big cups. We called that about a 0.775 in the right eye and a 0.85 to 0.9 in the left eye. Certainly that catches your attention. Doesn't mean that she has glaucoma. I do agree that the discs are they're bigger than normal as well. So big disc, big cups, but certainly that catches your attention. Let me make you feel a little bit worse. OCT. You take a look at the OCT, this structure, objective structural test, both the ganglion cells in the right eye, ganglion cells in the left eye, significant flagging of the ganglion cell structure, right eye and left eye, and also the retinal nerve fiber layer. The average RNFL thickness was 64 in the right eye and 61 in the left eye. This is certainly concerning. This is a statistical deviation from what we'd expect for a patient this age. Does this mean they have pathology? No, but there's a low chance that this is normal in a normal. These are normal. Could it be? Yes, there's a certain percentage of the population that, less than 1% that falls in the red, but this certainly is concerning there. So nerves are concerning. OCT is concerning. Let me make you feel better. The visual field looks pretty good. Visual field looks real good. One of the students on this day said, could you have much better of a visual field? And the answer is no. These are wonderful visual fields. So, to me, this is a conundrum going, visual field looks fine. And we all know that mild glaucoma, by definition, has no visual field defects. You can have pre-parametric glaucoma, meaning before parametric visual field defects. glaucoma. You can have that where they just have structural changes, OCT changes, ganglion cell changes, neuroretinal rim changes, but they don't have visual field defects yet. That's the definition of mild glaucoma, visual field defects on swap or no defects whatsoever. So can you have glaucoma without visual field defects? The answer is yes. But man, if you had this degree of damage on the OCT, those numbers on the average neurofibrillary thickness, you would think you have something. So it's a conundrum here. Let's get more data. And this is an ideal case where you're going, man, is this glaucoma? Is it not? And you've got the photopic negative response. Again, they did the OCT, the fundus photos, and the visual field did not add up at this point, and the ERG was crucial to help break the tie. How worried should we be at this? And I'm looking at the W ratio. What is the W ratio in terms of the number? The bigger the number, the better. Okay, the bigger the number, the better. Same thing for the percentage as well. If this W ratio is 11%, 11% or less, that would be concerning. We are not anywhere close to that. This is telling us that we have ganglion cell good function. The ganglion cells are functioning well, so we've got a good functional test and a good functional test. And I think this patient just has large cups because they have large discs, and that this is red disease on the OCT. This isn't necessarily pathology. This is red disease. And because of this data, because of the ERG, we are monitoring closely at this point. I'm not going to let her go away for 20 years, but we are monitoring closely. I don't think there's any way that you can have that good a function on the ERG and that good a function on the visual field if you truly, truly had that degree of structural damage. Okay? Not everybody falls in the green on an OCT. There's a certain percentage of normals that just don't fall in the bell curve. They're still normals, but not all normals fall in the middle of the bell curve. Some fall in this extreme end of the curve, and some fall in this extreme end. I think this patient has red disease. So we're monitoring closely. ERG gave us a higher level of confidence that, you know what, we can monitor at this point closely, educate the patient well, and it would have been harder to watch this patient if we had not had that ERG data, if we'd not had that photopic negative response. It allowed me to sleep better at night knowing the ERG data was normal. So as I said before, you wouldn't want a complete cardiac picture without an EKG. You do not want a complete posterior segment picture, whether it's retina, optic nerve glaucoma, without an ERG. Pair it with your structural tests, OCT, ganglion cell structure, pairing it with your ERG to give you a better picture. Knowledge is power. So again, appreciate your time. Nate Lighthizer.